I'm Dr. Sheila Cohen-Furr. I'm a practicing psychologist in Boca Raton, and I'm on the Ruth Rales and Norman Rales JFS Board of Directors. I welcome everybody to this webinar. Through the generosity of the Norman and Ruth Rales Foundation, we have been consulting with Dr. Susan Lehmann since last year as we are establishing a more robust psychiatry practice here at JFS, including partnership with Florida Atlantic University's Schmidt School of Medicine to establish a psychiatry residency program. Dr. Susan W. Lehmann is the clinical director of Geriatric Psychiatry and Neuropsychiatry and an associate professor in the Department of Psychiatry and Behavioral Sciences at the Johns Hopkins University School of Medicine, where she oversees geriatric psychiatry clinical services at the Downtown Hospital and Bayview Medical Center. She directs the Geriatric Psychiatry Outpatient Clinic and Geriatric Psychiatry Fellowship at Johns Hopkins. She is a national leader in geriatric psychiatry and in medical student and geriatric psychiatry education. She directed the Psychiatry Clerkship for the Johns Hopkins School of Medicine for 15 years and is a former president of the Association of Directors of Medical Student Education in Psychiatry. Dr. Lehmann is interested in improving medical student and general physician education in geriatric mental health. Dr. Lehmann is the recipient of a number of national awards and has presented and led symposia at the annual meetings of the American Association for Geriatric Psychiatry and the Association of Directors of Medical Student Education in Psychiatry on topics related to medical education, aging and ageism, and geriatric psychiatry. In addition, Dr. Lehmann has published articles, book chapters, and online educational materials related to a variety of psychiatric disorders in geriatric patients. She is particularly interested in late life mood disorders, especially geriatric bipolar disorder, mental health concerns in older women, and outpatient management of geriatric patients with psychiatric disorders. She is co-editor of the recently published book, Bipolar Disorder in Older Age Patients. Today's Grand Rounds presentation is specifically tailored for mental health and medical professionals, residents, and students. The title of the presentation is Practical Dementia Care, Recognizing Impairment and Management Challenges During the COVID-19 Pandemic. At the conclusion of Dr. Lehmann's presentation, we will have some time for Q&A. Please use the chat feature to post your questions to Dr. Lehmann. Also, since we have so many people from around the country on this webinar, if you could please add your location next to your name as it appears in your Zoom screen, we would appreciate it. Finally, on behalf of the Board of Directors of JFS, please join me in welcoming Dr. Susan Lehmann.
Thank you very much, Dr. Furr. I'm delighted to be here with all of you today. And I'm going to take a moment here to share my screen with you so that we can begin a conversation and talk about this important topic. Dementia care is always a challenging thing to do for families, for clinicians, and ever more so now during the COVID-19 pandemic. Shortly before I came here for this webinar, I was watching our leaders of Johns Hopkins who put together a video summarizing some of the work that's been done at our hospital during this pandemic. And the dean of our institution started off by calling 2020, he said, this is the year that changed everything. And I think that's a very apt description and that I think we all can very much relate to. So let's see. All right. I don't have any disclosures to make relevant to this talk. And by the end of the talk, the objectives that I have is that I hope by the end you'll be able to discuss the disproportionate impact of COVID-19 on older adults in general, as particularly on those with dementia, that you'll be able to describe some of the atypical features of COVID-19 illness as it might be presenting as cognitive impairment rather than some of the usual symptoms we think about, that you'll be able to discuss and identify 3 management challenges of dementia care during this current pandemic, as well as strategies that can be utilized to mitigate them. So let's start first with just examining and together the scope of the problem that we're dealing with. And for this, I'm going to share with you a slide that actually was put together by the Johns Hopkins University Coronavirus Resource Center, which you know has really been a leading source of information and data gathering during the pandemic. You'll see on this slide, and this is from November 27th, just a little under 2 weeks ago, this shows you a graph of the current 10 most affected countries in the world. And the green line is the United States. So you can see there was concern that there have been fluctuations. Things did dip down a little bit, as we know, during the summer, but then through the fall, we've had rising rates through November. And last night, I wanted to really update for us, where are we today? And you'll see this on the next slide. Now, the next slide, this slide looks dramatically different. And why? Because we had to change completely the numbers here on the y-axis. This shows, you can see that particularly over the past 2 weeks, there has been an explosion in new cases here in the United States. So the very first identified case of COVID-19 was January 21st in the United States. And since then, we've had nearly 15 million cases. 15 million cases and skyrocketing numbers that have gone up, particularly over the past 2 weeks. And remember that this is even before we're anticipating that the so-called surge, maybe the third surge related to Thanksgiving, that we would just now be experiencing those impacts. This graph shows for you as a slide of mortality, and you can see deaths per 100,000 population. The United States is not the highest per 100,000 population. Italy is, but we're up there. And since the start of the pandemic, we've had over 280,000 deaths in the United States. There has been a disproportionate impact of the virus on older adults. First of all, we know that older adults have been the victims of increased rates of mortality. This has particularly been seen among residents in nursing homes. About 80% of the deaths in our country due to COVID-19 have been in adults over the age of 65. Now remember, most individuals over the age of 65 live in the community. Less than 5% are living in nursing homes, and yet 20% of all deaths have been in nursing home residents, which is really, really drastic and quite devastating. I like this cartoon because I think it captures how we all feel. It says, if you can read this, your vision is 2020. What does it say? I think a year ago, none of us would have been able to predict this pandemic. We had no idea what was coming. And I think as someone who's been on the front lines working with our institution and our department, as all of you are in the audience, you can appreciate with me that we've been figuring this out as we go along. I've reflected many times about my own medical school education, which was now over 30 years ago. And I at no point do I remember that we ever discussed the pandemic of 1918. I don't know how much of that would be relevant for today, but in so many ways we have felt unprepared for managing this pandemic, and we've been making a lot of changes in policy as we go along. And so a lot of what I'm going to be sharing with you today is going to be information that we've been learning from newspapers, from reports, and then some from early studies that are coming out. It's just too soon to have the kind of studies and data that we really would like to have. And I think we're going to be learning from this pandemic for months and years to come. Before I talk about the specific impacts of the pandemic on individuals with dementia, I just want to remind you that before the pandemic started, we've had a very well described and good understanding of what are the principles of good dementia care, whether they be in the home, the community, or in residential settings. Number one, principles of good dementia care have included valuing the person, what we call person-centered care, knowing who the individual was and trying to tailor how we interact with that person and the care that we give based on their values and their needs. The focus is always on enhancing quality of life, finding out what sorts of activities and measures are important to the individual, striving at all times to provide care in the least restrictive way that preserves as much independence as is safe to do. And then using first and foremost as first line, non-pharmacologic measures in ways to be able to manage those individuals who have what we call the behavioral and psychological symptoms of dementia. And just to remind you, what are those? So those are the behaviors that often do cause some of the biggest challenges to families and clinicians, including agitation, psychosis, wandering behaviors. There are other ones, anxiety, of course, depression, insomnia. But in particular, it's these behavioral and psychological symptoms of dementia that we know, this is quite well documented and very well studied. They are the biggest cause of caregiver distress and caregiver burden. And of course, they cause considerable distress to patients as well. They are difficult to manage. There really is no pharmacologic medication that has been specifically approved to treat any of them, although a number of them are frequently used, particularly when non-pharmacologic and behavioral measures seem to be insufficient, when the behaviors present dangers to the individual themselves or to those around them. So these are difficult to manage, even before the pandemic, of course. What are the challenges that the disease presents for the management of individuals with dementia? Well, number one, the message that we hear all over and over again is the importance of physical distancing, the importance of wearing a mask. Those are well proven now, well understood public health measures that are good for everyone, whether they have cognitive impairment or not. But also the importance of isolation and quarantine for individuals who may be exposed to the virus. From a public health standpoint, we fully understand that the right public health approach is to isolate the individual, to quarantine them for a period of days, and that this is highly effective for preventing the spread of the virus to others. So from a public health standpoint, we know the measures that are essential for management of the virus and to protect the community. From a public health standpoint, we're always thinking about what are the measures that are going to protect the community at large, as well as vulnerable populations, which include patients, staffing, clinicians, families. Additional challenges that have come up have been ones that are really particular to, I think, the early stages, but are still ongoing at these stages of the pandemic as well, which is, do we have sufficient PPE, personal protective equipment? This was a significant problem early on, but it continues to be a problem and will be a problem as we're seeing a surge and increase in the number of cases. There are also other systems issues in the management, which include staffing shortages, what to do when there are staff who are quarantining because they are exposed and they need to be out, or who are sick themselves, as well as the need to provide sufficient training in how to use PPE and training in how to interact with patients under these new circumstances. And then there are additional challenges that really relate to COVID-19. And what's been very difficult are some of these aspects of this particular disease, which you know. Number one, it has such a long duration of an incubation period that after exposure, it's possible for someone to develop symptoms of COVID-19 within 2 days, but really anytime up to 14 days after exposure. Although it's most common for it to happen, for symptoms to present themselves after 5 to 7 days. Another challenge is the fact that the virus can spread through asymptomatic individuals. These are individuals who are infected with the virus but show no overt symptoms. They don't show any of the classic signs and they don't even feel ill. So there's a huge risk, and you can see how easy it is for them to transmit or infect other people because they themselves are not quarantining. They haven't been identified as being ill. We also have the fact that there is such a variable presentation of symptoms. We have a long list of ones, and the classic ones, of course, are difficulty breathing, shortness of breath, fever, headache, sore throat. But there are some other ones too. Some individuals may present with diarrhea, change in stools, and particularly for older adults or those who have cognitive impairment, some of the presentation may be more unusual. So COVID-19 is by a respiratory illness, absolutely. It's spread through respiratory means. However, the respiratory system is not the only one that is impacted and affected by it. And in fact, the longer that we are learning about it, the more we're learning about the brain effects of COVID-19 and the neurological effects. So particularly with older adults and those who may have dementia or cognitive impairment, it's very possible that the symptoms may present with mild or atypical symptoms such as diarrhea or drowsiness, a change in alertness. The older adult might not have a fever, and neurological symptoms, at least early on, could be the ones that predominate, such as increased confusion or worsening cognitive impairment or dizziness. Ataxia, referring to unsteadiness in walking. More severe cases could actually cause a meningoencephalitis. And we're beginning even to get the sense in individuals of all ages that the neurologic and brain impacts of COVID-19 are significant and can persist. And we're hearing more, and you've been hearing about this as well, of some individuals who continue to have what they describe as brain fog. So discussing these particular aspects of COVID-19 are extremely interesting, but are beyond the scope of this talk. I just wanted to share them with you to make the point that the symptom presentation in an older adult might be more in the neurological realm. There are significant impacts on patients with dementia from the pandemic. We know that this has caused on many different levels changes in routine, and that individuals who have dementia are very vulnerable to developing emotional and psychological reactions to significant changes in their routine that can present with anxiety and can present with agitation. Older adults with dementia have cognitive impairment that impacts their ability to understand the restrictions. It'll be harder for them to comply, whether in the home or on a medical unit or a psychiatric unit or a nursing home, with wearing a mask, for instance, or understanding the need to keep at a distance from other people, or the need not to touch their face, as we've all heard so many times to be able to do. And as well, the need for physical distancing may also increase anxiety among individuals with dementia who don't fully understand the need for it, but will understand that things have changed dramatically, and it will have, these changes will have an emotional impact. I think the pandemic has raised a lot of ethical concerns for which I'm going to just present problems, but I won't be able to really to give you solutions. And the ethical ones are, we're often presented with what really is the least harmful solution when it comes to how we manage interact with our older adults with dementia. Because implementing more restrictive measures, which we may need to do in order to prevent spread or to protect the individual themselves, will have an impact on clinical care and may also have a negative impact on what we know are best practices under normal situations for good dementia care by actually restricting individual patient rights or maybe even individual patient needs. These are really big questions, and they are really tough ones. And I think that the pandemic has put front and center, particularly for staff and physicians who are caring for adults in long-term care settings, as I'll be talking about shortly. So residents in nursing homes are, as we know, are especially vulnerable and have been hit particularly hard. As you recall, if we go all the way back to March, the initial epicenter for the virus in the United States was a nursing home in Seattle, as you remember. We've spoken about how nursing homes in general have had high infection rates, both here and abroad, and high lethality rates. And that a lot of the focus on caring for individuals in nursing homes has seemed to come on the late side. While we were focusing early on in the pandemic and providing adequate PPE, as we needed to for first line workers in hospital settings, in our emergency rooms, in intensive care units, very often we were not paying enough attention to the need for PPE for staffing in nursing homes. And public attention wasn't really paid enough to the needs of the staff in general. I can tell you that here in Maryland, where I'm from, universal testing of residents in nursing homes was not ordered until April 29th. And it really occurred after there had been hundreds of nursing home deaths here in Maryland. This is a newspaper article from the Baltimore Sun, which is our local newspaper, and it actually came out on November the 18th, talking a little bit about Belgium as an example of a country that was especially hard hit in Europe, with had a lot of confirmed cases, and particularly during the first wave of the pandemic, a majority of COVID-19 deaths were occurring in nursing homes. So what we have been experiencing in the United States, we're not alone. This has been happening and well documented in countries in Europe. So Belgium, for instance, has a population of 11.5 million people. They've had, as of November, about 15,000 deaths due to coronavirus. And in the first 6 months between March and October, you can see 61% of deaths occurred in individuals in nursing homes, really high. And among the reasons why this was happening is that nursing home patients who became infected with the virus were not transferred to hospitals for treatment and to get specific treatment. And this is something that was reported a lot during the spring. We were hearing about, for instance, in Italy, which was very hard hit with the virus in the first wave in the spring. Italy was restricting ventilators and intensive care unit beds to patients who were younger than the age of 80 and who did not have advanced dementia. Those were points of eligibility for ICU beds. And in fact, even in the United States early in the pandemic, there were emergency protocols that identified dementia as a poor candidate for ventilation. And I'll just remind you that among the things that have changed over the past 6 months are ways in which to manage the virus. And as you recall, early on, we were managing the virus and its respiratory impacts by putting a lot of individuals on ventilators as a main treatment approach. And there was a lot of concern about running out of ventilators. Over the past 6 months and 9 months, actually, we've learned a lot about the acute care of the virus, realizing that ventilators sometimes actually worsen the problem, and now we're using them much less often. But the point to make is that dementia was used as an eligibility criteria for use of these very low resource availability of ventilators and ICU beds. The University of Pittsburgh actually started a conversation. Let me just go back to this. In that they developed a point scoring scale, actually where dementia was not exclusionary, but rather based on the odds of recovery, which was really, in many ways, more progressive and a better approach to look at the patient as a whole, who was likely to benefit from it. And dementia wasn't necessarily one that should have been used as an automatic exclusion. On May 15th, moving ahead a little bit here in sort of the chronology of the pandemic, the Wall Street Journal had an interesting article, which at that point had noted there had been 28,000 deaths attributed in the long-term care setting here in the United States. And this article actually pointed out a policy of New York State at that time, which was in March, New York State had developed a policy whereby patients who were hospitalized with COVID-19 and were recovering had to be transferred to long-term care facilities, had to be, it was mandated. Yet there was no preparation or plan for the facilities to protect other residents. So these individuals who were coming to long-term care nursing homes, recovering from COVID, were still potentially infectious, were exposing long-term care residents, and then thereby increasing rates of the virus in long-term care facilities. And it was compounded by low staffing and a lack of testing. This policy was reversed on May the 10th. And then the CDC itself was evolving policies. And as the CDC in the spring was developing policies for testing for the virus, they developed a priority system in the spring, such that priority 1 included patients who were hospitalized and those who were, and healthcare workers who were symptomatic and had symptoms. They received the highest priority for COVID-19 testing. Priority 2 were those individuals in long-term care. So they were further down on the priority list. This was changed at the end of April, but again, this is now almost 2 months into the pandemic, where the CDC finally revised its testing priorities after it was pretty clear that the virus was rampant and causing a tremendous amount of morbidity and mortality in nursing homes. And then as of April 27th, their testing priorities now changed into a category of high priority, which is now the top priority, to include, of course, hospitalized patients with symptoms, healthcare workers, those in congregate living settings, and first responders with symptoms, but in addition, residents in long care facilities as well. So finally, patients who were living in long-term care facilities were considered to be among the high priority cases for testing, but not till April 27th. The impact of the virus in long-term care has been felt in other ways, not in addition to the risk of getting the virus and the high rates of the virus. And this is a very poignant article. Again, this was in our own local paper in November here at the Baltimore Sun, unveiling other troubles. And this is a picture of a woman. She's holding a picture of her mother, who was getting, as she describes, outstanding care in her long-term care facility. But then when the facility went on lockdown due to increasing rates of the virus, her mother died within 3 weeks. And she did not die of COVID-19, but she died because she was no longer getting the superior person-centered care that she'd be getting before. And what we've been seeing is the impact of lockdowns and quarantines is that family members have not been able to visit their relatives with dementia in long-term care facilities. And many of those individuals have really been dependent on family coming on a regular basis, often a daily basis or multiple times a day, not only for the company, but also to feed and help with meals, so that many residents with advanced dementia are not eating well or have not been eating well when family aren't there to assist. There have been concerns and real concerns about residents becoming victims of neglect because the staff are so stretched or understaffed and aren't able to give even the personal care and attention that's needed for things like good skin care and toileting. So there have been concerns about nutrition and adequate hydration, and we're hearing about residents who succumb not because of COVID-19, but what's been called a failure to thrive, which really has to do with inability to get the kind of individual care that's needed for them to do well in these settings. These are heartbreaking stories, but they're very real ones and show the impact of the virus in long-term care, in addition to direct impact of the virus itself. Well, what are we learning that's positive from the virus? And as I said, we're learning as we go. And in so many ways, I would say 9 months later, we're in a much better shape to manage, I think, this care of patients in all settings, even as we are becoming overwhelmed with numbers of rising cases. And while data is not as good as we would like, I'm going to share with you a number of recent articles that are coming out, that are advancing our knowledge and conversation about what are some seem to be good practices that we can learn from. So the first is an interesting study that was published recently looking at what types of family communication are effective and helpful, particularly in long-term care settings when family can no longer be there to visit because of quarantines and lockdowns in the long-term care setting. And what was done in this study is it was a survey of 161 adults living in the community who had a family member living in long-term care. And the authors examined communication methods that these family members were doing in the community since they could not do in-person visits, and surveyed them about the perceived impact on the emotions of their family member who was the resident. And what they found is that what they described as synchronous methods of communication, which examples were using a phone or sending an email, were more effective in eliciting positive emotions than what they described as asynchronous methods, such as sending a letter through the mail or dropping off gifts to be distributed. So this ability to be able to connect more in real time was more beneficial. And I think this is helpful just to even keep in mind. I'm going to be talking a little bit about virtual methods of communication, which are very important and have probably been a silver lining of this pandemic, that we have them available to us. But as you know, many individuals, and particularly those with dementia, really don't do very well on Zoom or FaceTime. They don't have the skills to be able to do it. And it just reminds us that email, yes, is very useful, but so is the phone. And that just even talking on the phone is something we shouldn't discount its value. And in this particular study, they found that it was very valuable. Another study here that I'd like to mention and share with you talks a little bit about the ethical and logistical considerations of caring for older adults on an inpatient psychiatry unit. And something that's of interest to me, particularly because I work and supervise the care on our inpatient geriatric psychiatry unit. And we've been thinking about some of these issues. So this article describes a particular case that posed significant ethical challenges for the staff. And the case was an 83-year-old man with Alzheimer's who had agitated behavior. And this individual, who was a patient on the inpatient psychiatry unit, had been exposed to another patient who ended up testing positive for COVID-19. And so as a result, he really needed to be quarantined and isolated to his room, but attempts to restrict him worsened his mood and his agitation, because he really was most comfortable with the freedom to just pace around the unit. He wasn't aggressive, he wasn't combative with staff, but because of his inner agitation, the staff found that he really did best if he could just walk freely around the unit. And when he was restricted from doing so, his agitation increased. They were not able to get him to adhere to masking. He didn't understand it. He couldn't process the need for it. And so the way they handled this dilemma of how to manage his case is they came up with a care plan where they decided that they would allow him to continue to wander and pace around the unit, but at times when other patients were in their room. They noted that he remained asymptomatic, and at the time he never met criteria for testing. But interesting that this is how this dilemma was resolved in this one particular case. And I'm showing it to you because I'm going to show you a very different example. Another article gives a different sort of a case report, also published recently in the American Journal of Geriatric Psychiatry. Again, talking about how to do safe, effective quarantine and isolation. This one describes a case of an individual with dementia in a nursing home and how they managed the ethical challenges. So the authors note that there are ethical concerns. As I had started and mentioned earlier in this talk, how do you safely isolate a patient and minimize harms to them and to others when there is significant cognitive impairment. And the authors note that we really they lacked, and we do still lack, guidance regarding when is it appropriate to use pharmacologic means or restraints, which are things that we are much less likely to want to do under normal situations. Under normal situations, again, to remind you, good dementia care would want us to be able to use non-pharmacologic methods, the least restrictive ones, but acknowledging that there may be times here when staff may feel like they need to do things that they normally wouldn't do. And that staffing shortages add actually to the problem, and particularly because it can increase risk to the residents if staff are sick and they're out because they're ill or because they're quarantining themselves due to exposure. Well, that increases risks to the other patients and residents on the unit, in that there's fewer staff there to help with their personal care, assist them when they're transferring and they're walking, which increases risks of falls. So they presented a vignette of a case. This was a case described of a 65-year-old woman with frontotemporal dementia living in the long-term care setting. She was exposed to a staff person who tested positive for COVID-19. The patient initially tested negative. And the staff here described what they did is they developed an isolation care plan. And they really tried, it sounds like they tried measures to really keep her to her room. They assigned an additional nurse during the hours when she was going to be most active, between 12 and 9 p.m. They had a nurse just assigned to her one-to-one. They thought ahead and provided her with additional movies. They had a tablet where she could access music. They brought activity sheets that she could do on paper, hoping that she would stay engaged and that she would quarantine and stay in her room. They too found that the patient, due to her cognitive impairment, was unable to comply with the room quarantine. But unlike the paper I just described to you on the psychiatry unit, they felt they could not let her walk around freely on the unit, and instead they ended up using a Jerry recliner restraint for up to 2 hours at a time. Although they described how they kept her engaged, how staff was with her, they didn't want it to feel punitive, but they felt they needed to do this so that she wouldn't wander around and be at risk to other residents on the floor. They also changed her antipsychotic medication to a form that was more sedating. And again, something that they likely would not have done under different circumstances had it not been for this problem. And then another paper I'm going to talk to you is about the use of telemedicine. And again, as I would say, the silver lining that has come from this pandemic really has been that we were all catapulted into the world of telemedicine and telepsychiatry. We all had to very quickly go from nothing to full throttle within days or within a week, learning how to use it effectively. Something that we have as a field wanted to be able to do for years, but we're not able to do because it was not reimbursable by Medicare, and because the usages of telemedicine before March were very restricted and limited just to very specific situations. This is an interesting paper that talks about the protective impact of telemedicine on persons with dementia and their caregivers. And interestingly, it's a paper that was written by authors from Hong Kong, who described their experiences with 61 older adults who had dementia and their caregivers. And they did a study that was only for about 6 weeks, but they had an intervention and control group, and which consisted of individuals with dementia and their caregivers were a dyad. All dyads received phone contact weekly, but half of them, which was the intervention group, had a telemedicine appointment in addition, either by Zoom or FaceTime, with a healthcare provider. And what they reported is that those who had phone support only, they noticed that over the 6 weeks, even over just 6 weeks, the older adults with dementia had worsening cognitive impairment, just from, and they don't describe all the reasons why, but we could imagine probably because the kinds of activities and supports that normally would be there that would provide mental stimulation weren't there, but also the caregivers had decreases in their overall physical and mental well-being and felt increased burden. Whereas in the intervention group that had, in addition, this regular telemedicine meetings with a healthcare provider, actually improved on measures of resilience and well-being, suggesting that this has a very important role for patients who are dementia, as well as their caregivers. The challenges for home care for family caregivers have been really considerable. It's been huge because with the pandemic, senior centers have closed, adult daycare programs have closed, and the kinds of places that have been good for individuals with dementia, providing structure, providing stimulation, and quite simply also providing respite for families aren't available. For those family members who have had in-home aides and in-home assistance to help with care, it's been more challenging to obtain that care, to retain that care, and comes at a cost of stress for families who are always worried about the individual and the aide who's coming in their home. How well are they masking? How well are they protecting themselves using physical distancing that doesn't put them at risk of being an asymptomatic carrier or becoming ill themselves? And again, remembering that sometimes the most infectious time for the virus is usually within 48 hours before there's the onset of symptoms. So this has created an additional aspect of stress and strain on families. And as a result, family caregivers are providing much more care than they've had before. The challenges for patients themselves from an emotional and psychiatric standpoint, even for those who are living in their homes with families, have been considerable because there's less structure available. So there's the problem of boredom, of what to do and the kinds of activities that are open to them that can be engaging. A lack of exercise, and I think particularly during the winter months now, maybe more so where I live in Maryland than in Boca Raton, where there's probably nicer weather and people can't go outside. It's a concern that when the weather is really cold, not being able to go outside and even go for a walk. Accessing virtual programs, there are quite a number of them. I'll talk about them in a moment. But just as we who are clinicians and providers can develop Zoom fatigue from staying on Zoom all day, and children can get Zoom fatigue from school, so can our patients and family who have dementia and cognitive impairment. It's hard for them to pay attention. It may be hard for them even to access virtual programs. The change in routine is stressful, and the difficulty of understanding the need for masks is stressful, as well as physical distancing. So what would be the recommendations for families with home care? Well, what I say to my families is just to remember the importance of structure and routine, very important for themselves and for their loved ones, that to really try to keep to regular routine in terms of going to bed at the same time, waking up in the morning, regular meals, and including daily exercise. This goes for caregivers as well as for the family members with cognitive impairment. Exercise really doesn't need to be working out at the level of a gym, but really just walking would be really excellent exercise to try to do some of that every day. And I do talk to families that where they can to try to think of opportunities for respite, because it's 24/7 for them and very challenging. Maybe respite is having and someone else in the family come for an afternoon or staying overnight, just to give the individual time away to be able to go out and just spend some time doing something else, whether it's going for a drive or going for a walk or a jog in a park. And I have been really encouraging my families to work on their literacy for use of technology. It's interesting that our geriatric psychiatry outpatient clinic, I mentioned to you that we really went 100% to telehealth in March. Initially, the majority of the appointments were by telephone because only a small minority of our patients and their families were comfortable using Zoom or using video visits. That has changed a lot over the 9 months. We've worked very hard to help teach families and patients who can do this how to use FaceTime. A lot of patients has gone into working with video visits through Zoom and also through our MyChart through Johns Hopkins. And now 9 months later, phone visits are still being done for those who have no access to the internet or really cannot use a computer, but they're now much, much less and are really in the minority. So we have been successful in improving literacy for technology. And I tell my families to really embrace the virtual opportunities that are there. Number one, to use telemedicine and telepsychiatry. And this is not only for psychiatric appointments when available, but also for general health. We know that even before the pandemic started, families and caregivers of adults who have dementia and cognitive impairment frequently put their own health needs further down on the list and don't take care of their health. It's important they do. And if that might mean having an in-person appointment, if it's for your own cardiologist, well, then go by all means. But also to avail themselves of opportunities to manage their own health through telemedicine. And then there's been a huge number of virtual resources, and they can be helpful even for short periods of time. There are exercise classes online, free classes that teach relaxation, yoga, chair yoga. The great museums in this country and the world have free tours, and they can be very enjoyable. There are tours of our national parks. I actually saw recently it's possible to go on a virtual safari, looking at animals in Africa. So these can be amazing opportunities that can provide, worthwhile diversion and stimulation. There are online resources to be able to access classics in Broadway shows, movies, and classic TV shows. The Alzheimer's Association has virtual support groups, and there are virtual senior centers that are not limited by geography, that have classes, have lectures, have activities and exercise classes that are available for families to pursue. In terms of long-term care, for those families that have someone in long-term care, I think it's very important, particularly during periods when you cannot visit. And what we're noticing over 9 months is that there were times, particularly later in the summer, early in the fall, where a lot of long-term care facilities started to relax their regulations when the rates went down. And family members were often able to come in maybe once a week for an hour, or at least to be able to visit their loved one outside in a garden. But at those times when you're not able to go, share information with the staff so that they know the personal needs, so they know your family member better. What are their likes and dislikes, their preferred name, hobbies? Remind them that if the family member needs help with eating and drinking, and to definitely schedule phone and video calls. I do think it's worthwhile to send notes and cards, but I am paying more attention now to that study that said phone and synchronous contact is even the most meaningful. I want to say a word about the vaccines here, because you know that Moderna and Pfizer have two vaccines that are really ready for distribution once approval. Their trials of both have included adults over the age of 65. They have not been tested in long-term care residents. Tomorrow, as you probably heard, the FDA's advisory committee is going to meet to consider emergency authorization for the Pfizer vaccine. And here's one way in which we're in a different world than we were in March, which is the CDC is prioritizing for the very initial rollout, what they're calling phase 1A. It's going to prioritize both healthcare workers and residents in long-term care. And that's a great thing. But to remind you that when the federal government improves the vaccine, it will be under an emergency use authorization such that facilities can't mandate it and states don't necessarily have to adhere to it. So in summary, I just want to share with you that 9 months into the pandemic, we don't have all the answers we wish we had. I think the pandemic has raised some very significant and important ethical issues that we are still struggling with, and that providing high quality dementia care, both at home and community settings, as well as in long-term care, does present significant challenges that we haven't had before. I think as we continue to move forward, there's an opportunity to continue to develop really better guidance for staff in the long-term care setting, addressing their need for emotional support as well as continued need for PPE, and recognizing the additional needs for support for our caregivers, increasing digital literacy for patients and families, and really as well the need to continue to study outcomes and best practices. So thank you very much for listening. And I know that, sorry, I had a lot to share with you. And
Dr. Lehmann, thank you so much. Your talk was quite informative. I have a question I wonder if you could address. You've been talking about the family system and the dynamics of dealing with this during COVID. Would you address what it's like for caregivers, family members, who either have not been able to see their family members in long-term care facilities or have not been allowed in the hospital after their family member is diagnosed, and the anxiety, and I can speak to this personally, of not being able to visit someone who has COVID and is dying. Could we work with family members too? And what are your comments about how to support the family who's not able to be there for their loved one?
this is a huge issue. And I think we're going to be seeing for long times to come really the psychological impact of this. I think it's been very hard for families. I think there's been a lot of heartbreak, the feeling like I wasn't there. Maybe because I wasn't there, it contributed to my loved ones passing, and maybe they passed a little earlier. I should have been there to hold their hand. I wish I could have been there with them. I think there's going to be a lot of feelings of guilt. And I think there's going to be a lot of sadness and bereavement and grief. We're seeing this. People who can't go to funerals, and our family members who are watching on Zoom and FaceTime because they can't be there. So I think we have to be acknowledge and allow people to validate that those are understandable feelings. They did, there was nothing else they could have done. They can't feel guilty about it. It was really tough. And I help people just work through and accept that how difficult it was, acknowledge and validate what their feelings are. But I think we're going to see the emotional impact for a long time to come. And what I'm not really seeing yet are really enough reports and studies about it, which I think we will.
Thank you. Joanne Baskin from Montreal has written in the chat that their organization has moved their entire center online with various virtual programs. So technology, and you've been talking to us a lot about that, technology is being employed all over North America to try to help people to cope with this.
Well, and I think it really is wonderful. I think we are really living in an amazing time. We're really living in an amazing time that we are able to do this. I've often thought that if the pandemic had really hit us 10 years ago or even 5 years ago, we would be much less prepared. No one heard of Zoom before. The fact that it was ready to go and it works as well as it has, and it does, is really fantastic. And I think that's great. And I think it is great that it's being used. And I think all of us in the field do see that. We hope there will be a way to be able to continue with some degree of virtual connections with patients. Maybe we don't want to do it 100% once the pandemic is over, but there are going to be ways that we hope we can continue to use it to extend our care and extend our reach.
Well, unless we have any other questions, Dr. Lehmann, I want to thank you for all the guidance and the help you're giving to our agency, Jewish Family Service here in Boca. And I'm sure the others on this call now will be taking back a lot of great information and suggestions about how to provide better care to our patients and the families of our patients. So we thank you so much for your time with us today and all your input. Thank you.
Thank you so much for having me.
A pleasure. One question, Dr. Lehmann, will the PowerPoint be made available?
Sure. Who should I send it to? I can certainly send it. I think one thing I would ask, could it be, if it's distributed, could it be distributed as a PDF rather than actual slides?
I would think that we could take care of that.
Usually I prefer to be done that way.
And so people who would like the copy of it, perhaps they could send an email to JFS, and we would see that they get it in the form that you've requested, Dr. Lehmann.
Okay, thank you.
I'm watching the chat. Lots of thank yous, lots of appreciation, Dr. Lehmann. It was a great talk.
Mm-hmm.
Albert JFS in West Palm Beach has a coping with our new reality social isolation that's been very important for supporting people. And they have about 30 to 40 people each week.
That's wonderful.
A lot of creative solutions in agencies.
Yeah, no, this definitely is the silver lining, which is the stimulus for innovation and using the resources that are available to us.
Absolutely. No, I don't
That's
see
nice.
any questions.
Yeah, I'm just looking, right.
Yeah.
I guess I will add, I'm sorry that the talk was a little bit, there was more to say than I thought. And if anyone has a question you think you want to pass on to me, I can respond to it. It's interesting one about the increase in death for dementia due to lack of social. I think, we don't have a way to track that. I think there is the sense that there have been, and deaths due to lack of social interaction and stimulation. There's a sense that is happening. We just don't have a way to track it and know. That's nice. There's a lot of comments.
Trying to get the best email for people to request the PowerPoint. So bear with me.
Sure.
Well, in the absence of that, and somebody asked for mine personally, I can expedite it. So I'm happy to do that.
So let me ask you, who should I send the PowerPoint to?
Yeah.
Who do you think?
I don't have a response from.
Should I send it to Bonnie? She was been my contact.
Yeah, I would send it to Bonnie. If someone asked for my personal email, I can help expedite that if something falls through the cracks. So if you could send it to Bonnie, Dr. Lehmann, and I posted here on the chat mine, we'll make sure people get what they need and want.
And someone's asking about support groups for bereavement, and maybe that's someone who's looking for something in Florida that you know about. I don't know.
Okay, well, again, I would think of hospice by the sea here, but during these challenging times, I'm not sure if they're doing in person or Zoom support groups. I know they used to have them, but I really don't know. But you can, for those who are local, certainly always reach out to our JFS, Norman and Ruth Rails JFS here in Boca, and we'll be happy to share with you what we know and what we can help connect people with. And if you see on the chat now, Sippy Rosen, who's on part of our clinical staff, has said that we do have multiple virtual bereavement groups going on now. So
great.
That one.
Excellent.
Yeah, our agency has done an awesome job with providing telehealth through all this. It's been amazing to me as
that's wonderful to hear.
Been able to do and provide support, and the numbers in our psychiatry program is growing so much.
And what we've been doing it before we've really we're trained to do it. So I mean, how do you lead an effective group therapy online? There's some, those are maybe some new techniques that we're just that we're doing it, but learning as we do it. What are the best ways to do it? It's not so easy, when people aren't in the same room and they're not really all looking the same direction.
It's not the same. It doesn't have the same level of connection and intimacy that we would like when everybody's in the room, but it's worked a whole lot better than I think we thought we would. And it's a lot better than not having it at all.
Absolutely. And we've, and there are privacy issues. What about someone else is in the house and seeing other people on the screen? It's, that raises different questions that I'm sure you've grappled with also.
So what I'm seeing comments now in the chat of different programs around the country, support groups in Baltimore, here in Boca at FAU, at Memory Center, Lewis and Ann Green Memory Center, that there
Great.
are programs. So you know, agencies have stepped up to meet the need, be creative. Do you think we will have more dementia cases as a result of social distancing?
That I don't know if if that's going to be a cause of dementia necessarily. That's sort of a, yeah. I mean, I think not sure what that means in terms of social distancing and in what situation.
Yeah, you mentioned cognitive fog. I think you talked about COVID fog.
Yeah, I was thinking more about that as a result of the virus. You know, people, there's what they describe as the long haulers, people who don't fully get well and feel like they still can't think very well. I'm concerned about that, residual cognitive impairment difficulty with attention, memory, concentration. That's a result of the virus. Physical distancing. You know, what we do see is that if people aren't, I think if someone has a propensity, I think we are seeing more depression, we're seeing more anxiety when people who are more stuck at home. And I guess it's possible for there to be worsening cognitive impairment. I don't know that it will induce new dementia. Is what I would say.
There's a question as, would COVID-specific support groups be more appropriate than general support groups at this point?
Well, you can answer that probably better than I can, because I think that's probably a debate. Some people do better when it's a particular theme with people with the same problem, and others do better when it can talk about in general ways. I mean, right now, I think COVID is the #1 issue on most people's minds and its impacts. It's hard right now probably for any support group not to include that, because it's so pervasive and it's affecting family relationships, financial strain, you know, the economics, access to healthcare disparities. It's been a factor that's been affecting the political tone in the country, and that's inflamed people. So I think it's, even if you don't mean it to be a COVID focused group, I think it's hard for it not to be an important theme.
I don't think there's anyone on the planet who's not affected by COVID. So it's pretty pervasive.
Exactly.
Right.
All right.
Well, thank you again, Dr.
Thank you. It's nice to see you again. Thank you so much.
We really appreciate all you're doing to help us in Boca and now across the country. So thank you very much.